Rajesh Upadhyay, Dean, Indian College of Physicians, and I'll be talking about the gap between clinical guidelines and medical practice and how to bridge that gap. Well, guidelines have become very popular. All associations on the national front as well, ICMR and various other institutions are bringing out guidelines, and they are very good guidelines, but in actual practice it is not being followed the way it should be. There was a study from Ujjain in which they looked at 683 prescriptions for looking at the guidelines for treatment of diarrhea in children below 12 years, and found that only 5% or so had followed the guidelines. Similarly, Western studies are also telling us that in 40 to 50% of cases guidelines are not being followed, and in about 25% of cases actually it is a wrong treatment, non-scientific treatment and potentially hazardous treatment. Therefore, we have to look at the reasons why this is happening, and there are a multiple of reasons. First of all, I'll let you know some examples. Say it is recommended that antibiotics should not be used in mild pancreatitis, but practically 70% of physicians are writing it. Why is that so? Well, probably lack of knowledge and sometimes patient pressure and even the medical fraternity pressure, because if I don't write, somebody comes for the evening round to see the patient and they say, oh God, probably Dr. Upadhyay has missed to write the antibiotics, and therefore they put the antibiotics on. And the best example of not following the guidelines was really found during the COVID, when the guidelines were coming out at a rapid pace and being updated on a weekly basis by AIMS, ICMR, government and all the bodies. But what was happening on the ground? None of the guidelines were being followed. And this was because there was a panic situation, fear to lose the patient, and in absence of any clear-cut treatment, doctors were writing all available treatment, which was clearly unscientific. So these are some of the factors. Another thing is, I will just quote an example of that the best way to diagnose NASH is to do a liver biopsy. Now tell me, how many places in our country have got liver biopsy facilities? How many places have got trained histopathologists to examine the histopathological specimen and provide clear answers? The answer is very few centers have got it, and therefore it is important that if you are producing such guidelines that we give some cascades. We advise that if the liver biopsy is not available or if the patient refuses it, what next should be done. So these are very important. In fact, when we did the guidelines for typhoid fever for the API, and I was the principal author for that, I remember it was an eye-opener for me. We had gastroenterologists, we had physicians, and what we did was we got about 12 general physicians from all over the country. And when we started to make the guidelines, the first statement was diagnosis in the first week of typhoid fever, and everybody was very clear, blood culture. We all know that. But then the hands raised up immediately from the general practitioners, and about 60% of them has said that there was no facility for blood culture in their region, and neither did they have access to the typhoid test. So all they had was Vidal test, and right in the beginning we had said Vidal is no good as a diagnostic method in the first week. So what are they left with? So we decided that based on certain clinical features, we should write that a probable diagnosis of typhoid fever can be made and treatment may be started. So this is a clear example of how to make guidelines with collaboration, and do not forget that the persons who are really treating the disease may be in remote areas of the country, and therefore we have to provide options. Broadly, the problem of non-adherence to guidelines lies with the doctor's factors, the guideline factors, and then there are external factors. Many of the things, as I mentioned, may not be available. The financial constraint is there, the staff constraint is there, and so on and so forth. So broadly, it is very important that guidelines must be, and I am coming first to the guidelines, what we can do, because we have to find solution for this. Guidelines certainly must be evidence based, but the important thing is to collaborate with all the stakeholders before we make the guidelines, because collaboration and consensus is the key to acceptance. So collaboration and acceptance has to be there. Secondly, it should certainly be very scientific, and detailed document can be there, but it is very important to have a single page summarized statements, so that if somebody wants to look at it, it just provides clear answers as to how you should manage your patients. Lastly, I would say that we should also involve patient groups in the actual making of guidelines, and that will provide, because sometimes the patient's expectations and concerns are different from ours. So all that should be taken into consideration before making a guideline, and a patient information sheet should also be provided. So these are some of the guideline factors. Then I come to the most important thing, which is, once we make the guideline, first of all the methodology should be unified. The methodology, each one makes a different method, uses a different methodology. So methodology must be correct, collaboration of all stakeholders must be there, and consensus must be there, but dissemination must be the most important thing. So how do you disseminate? So if you have all the collaborative consensus guidelines, it can be put in all the stakeholders' journal at the same time. Large number of meetings conducted in order to promote and popularize the guidelines, and it should be able to reach out to the person who is practicing in the most remote areas through leaflets, through whatever other means we can provide. So dissemination is very important. Unless the knowledge is there, it cannot be implemented. You see, the knowledge will increase the information, and it will change the attitude of the physician, and the attitude will then lead to change of behavior of writing their prescription. So dissemination is very important. So I have clear message to all the associations to certainly base the guidelines on the grounds that I have just mentioned, have summarized statements, have collaboration, have consensus, have patient involvement, and make sure that there are patient documents as well. But now, just by having this, we are not having a credible guideline. For a credible guideline, we also need government involvement. So how do we do that? And what I propose, and what I have proposed in this meeting, is that there should be a national nodal body which should be looking at all the guidelines which are coming out from various associations. Such a nodal body can be called the Indian Institute of Clinical Excellence, on the same lines as the NICE of UK. And the Indian Institute of Clinical Excellence should finally endorse all the guidelines. So the guidelines, once they are prepared, they should be sent to the Institute of the ICE, which is Indian Institute of Clinical Excellence, who will get it external reviewed, peer reviewed, and discuss within all the stakeholders. Once it is finally given a shape, it can be put on their website for 4 weeks. Any proposals which come can be incorporated in there before the final document is made. And once the document has been made, it should be then endorsed by the ICE, which is Indian Institute of Clinical Excellence. So once you have ICE endorsed guideline, I think everybody will follow, because as you know, for many diseases there are multiple guidelines and people are confused as to which guideline to use. So this will become one government endorsed guideline, which will be the most credible guideline and everybody will be able to follow. So these are some of the solutions which I have provided for increasing the changing clinical practices according to the guidelines and trying to standardize the healthcare treatment in India. Thank you very much.